you very much for having me back to celebrate your 5th anniversary and the many successes that you have made. And again, I too am honored to have been part of this collaboration. I'm going to review where the bone marrow transplant program here has been, is now, and where it's going with regard to our program at the Dana-Farber. Maybe. So basically, the two hospitals are much more similar than they are different. And when you actually look at this picture, you can see that you have a much prettier hospital than we do in Boston. So I'm very envious of that, along with better weather and nicer people. So you're starting definitely with a leg up. But we have been now in a very close collaboration for the last 3 years, and hope to see this going forward. In America and basically throughout the world, when people talk about academic medical centers, which is what this is, they have defined that there are 3 missions of an academic center. And those missions are patient care, teaching, and research. And you must constantly be working on all of those missions to be deemed a success. Lately, and probably in the last couple of years, the global health and the global outreach has been added to those missions. And I think this is much more in its infancy and still needs to be developed more, but it is now clearly a core component of any place that calls itself an academic research center. So I'm going to go through each of these missions vis-a-vis the bone marrow transplant program here at 57357 and talk about where we have been, where I think we are now, and where we're going. And I'm doing it a little bit out of order just because I like that way better. So basically, teaching and training is a core component of any academic center. And it ends up being a problem because it takes away from patient care and it can take away from research. But if you don't make time to do teaching and training, you're not building a future for your division. So in the past, we had done a lot of teaching and training, we thought. There have been visiting lecturers, and there's been small group teaching and joint rounds with both me and the bone marrow transplant program, Mark in neuro-oncology, Kathy with nursing. And they look sort of like this. Here's one of the lectures, and here's Mark giving small group rounds probably 3 or 4 years ago. Now, I think we've already made a big step forward. Currently, the teaching training collaboration that we have is a year-long bone marrow transplant subspecialty fellowship at DFCHCC, which is who we are. It's so long to say Dana-Farber Children's Hospital Cancer Center that I'm just going to call it the Dana-Farber from now on, or Dana-Farber Children's. But currently, we have that year-long fellowship in place. There are written out, codified expectations for the fellow who comes. Those expectations touch, again, on all of the different arenas. There's clinical expectations, teaching expectations, experience in transplant-related areas, and research expectations. The clinical, and Dr. Yasser Elbori, who many of you know, is finishing up his first year of this fellowship. The clinical expectations are 3 months of inpatient co-attending with me or one of the other senior physicians, 2 to 5 bone marrow harvests, which Yasser has now successfully done, 2 to 5 new patient evaluations per month where you decide if a patient needs to go to transplant, what the conditioning regimen should be, what the past issues are that may be affecting the transplant. We have a multidisciplinary chronic graft versus host disease clinic that occurs every other month, and Yasser attends that. And then he does outpatient follow-up clinic 2 to 5 times a month. This is what our inpatient unit looks like, where Yasser would be. All of the rooms are single rooms. They're HEPA filtered. There's a bed near the window that the family can sleep in. There's the equipment against the wall. We have mood lighting so that you can flick a switch and have the lights on the ceilings that you see there. Those panels reflect music or different moods that you're in. And it's a relatively state-of-the-art unit. These are daily rounds that Yasser also participated in. I don't know if you can see him back in the corner there looking very involved. Our rounds include a nurse practitioner, a fellow, a pharmacist who comes on rounds with us every day, a nurse, and a resident. And all of those people round on all of the patients jointly. And this was 1 day before I was going to Mexico and 4 days before I was coming here. And I was obviously very excited about something and using, hopefully, that opportunity to teach. The fellow themselves has teaching obligations as well. So there's an expectation that they would do one staff development conference, which is multidisciplinary for all of our attendings, fellows, residents, nurses, psychosocial clinicians, and Yasser did a very nice one. He gave resident teaching sessions to the inpatient residents that occur weekly. And then we have a curriculum online, and we use it to document that our attendings are up to date in all of the different areas of transplant that they need need to be certified in order for us to get our FACT, or Foundation for the Accreditation of Cellular Therapy, documentation. And so we decided, because it's very hard to prove that every attending is up to date in all of these different areas, that we would put PowerPoint lectures online, and then the physicians could read them, and we would have documentation that they read them. Net learning, people love it in America. And so Yasser did actually the first presentation on the management of CMV infections, and he and I did about 400 versions of it, but it is now online. And again, if any of you want these presentations, I am happy to send them to you. This was from Yasser's presentation. He talked about a project that we did, which I will talk about in a little bit, and also gave to everyone in our group a history of 57357 and how it had been built over the years, and then shared this very lovely picture of the bone marrow transplant team so that everybody knew who our colleagues were here in Cairo. The fellow also spends time in transplant-related areas, radiation oncology, the unrelated search coordinators, the tissue typing laboratory, the hematopathology laboratory, and we have a special ID service for immunocompromised host patients, and those are all areas that Yasser spent time in. Areas that I was thinking about for the future is more fellows come would be spending time on the adult transplant unit. Our adults transplant 450 patients a year at the Brigham Hospital, and we do over 100 a year now. So between us, we have over 500 patients being transplanted in the Longwood medical area, which is unrivaled in any other part of the country. I think spending time in pharmacy, spending time in the ICU, and spending time in the apheresis unit would also be good areas for collaboration. Sorry. There was a research component of the fellowship. He and I wrote a review article on transplant and thalassemia that's in its last corrections before being accepted. We did a collaborative project with the people here, which I will tell you about down the road. And then the expectation was that he'd be involved in 2 to 3 clinical research projects. And the things that you learn when you do a research project is how to make an IRB submission, how to do the statistical modeling. And we're fortunate to have a statistical department, as are you, that can do a lot of the statistics for us. But as the PI, you need to be involved. Yasser's working with a student that was given to me this summer for free from a program in the Boston area. So he's learning how to mentor that student through a research project. And so the student goes to him, and then Yasser would come to me with issues. And then at the end, the expectation is that there's a poster or an oral presentation. So that's very good, but as we think about down the road, I think we can have our expectations be even higher. There's currently, as Mark alluded to, a formal Children's Cancer Hospital of Cairo, of Egypt, and Dana-Farber Fellowship Training Program. There will be a general oncology program that I'm sure you will hear more about over the years to come. But for the stem cell transplant program, as with the neuro-oncology program, we will take 1 to 2 dedicated fellows a year. The things that I hope to do better than I did for Yasser, besides spending more time with him, is to give more exposure in the stem cell transplant related areas, more work on protocol development for interventional protocols instead of retrospective studies, and a lot of work which I think would be very useful when they came back to either to here or to other programs in the Middle East on QI and metrics. So as Sharif says, you can't change what you can't measure, and to develop actually very, very robust quality improvement programs and policies will be the foundation for transplant as it moves forward here. We also, down the road, have a new global health fellowship at the Dana-Farber, where usually one of our 6 fellows that we take each year to train in pediatric hematology oncology is a dedicated global health fellow. So they have come in saying that they want to make a career in global health. And Mark and I have been very interested in having those fellows rotate through here. And I think that the key to collaboration in any universe is that it be two-way, and that while we come here, that people come to us as well. And then I've been working for months with Allah to have a visiting professorship or professor exchange program where he and other consultants in the transplant would come to Boston, give lectures, see patients, and then obviously our consultants can do the same. Moving on to research, in the past, Allah and I in 2010 did an abstract that we submitted to SIOP comparing the outcomes of aplastic anemia between the 2 institutions. That's fine. We haven't written it up into a paper. I think there's a lot more that can be done. Our In terms of the present, the project that Yasser and I and Allah and Hanafi and Imad have been working on is looking at comparing the toxicity between two different conditioning regimens for neuroblastoma. And this is a copy of the abstract that was accepted at ASHFO. And I can talk about the results, but I think actually in this context, the process is more important. And what I really liked about it was that we brought to the table some very innovative approaches to how to do cross-institutional, cross-country research. So what we saw very early on is that we would have insufficient numbers of neuroblastoma patients to actually look at an endpoint of efficacy. So whether Bumel, which you use here, or carbo-VP melphalan, which we use in Boston, is a better conditioning regimen for neuroblastoma, will take years to decide and will require trials that involve many, many institutions. But what we did have enough patients to look at here is toxicity. And so we looked at bone marrow, kidney, and liver toxicity compared to the two regimens. We put it through both IRBs, which was sort of, again, a novel step, and our IRB signed off on the data from Cairo and vice versa. And then I think the thing that I maybe liked the most is that we had multiple levels of collaboration from both institutions. Professors were involved, Allah's the last author, consultants, fellows, medical student, and it served as the medical student dissertation. And so we really brought all layers of the bone marrow transplant community together for one project. And as Mark was saying, you know, one time you'll be last author, one time you won't be on the paper, and one time you'll be in a more prominent position, but all of it moves the field forward and gives you incredible practice in working together. So we currently have, this was a poster at ASHFO in New Orleans back in February, March, in March or April, and I had a beautiful picture of Yasser in front of the poster, and I spent literally an hour trying to import it into my PowerPoint to no avail. So you can imagine Yasser and Hanafi at the poster, and the manuscript is now in its second draft. What can we do in the future going forward? Well, I think we can do additional comparative studies. The thing that we have on deck coming up is Hanafi is looking at prophylactic, beginning with Allah, of course, using prophylactic antibiotics in the auto transplant patients. We don't use prophylactic antibiotics in our auto transplant patients, so we will go back and do a poor man's randomized trial at looking at the incidence of bloodstream infections in your population versus our population. We also will begin more formal academic exchanges, including being on editorial boards for journals coming out of Egypt and reviewing manuscripts, and then co-written chapters and review articles. And then I think the gold standard and the thing we need to do the most is to have prospective protocols that either start here and then are imported into Boston or open at both institutions simultaneously. And some of the areas of need are approaches to patients lacking family donors here, and also the approach to rare diseases such as dyskeratosis congenita. We just opened a protocol in Boston with a reduced intensity regimen for dyskeratosis congenita. One of the young attendings and I did it. He did the vast, vast, vast majority of the work. It is incredibly novel. We are giving only fludarabine and Campath as a conditioning regimen for dyskeratosis congenita, which, as many of you know, is a bone marrow failure syndrome with a DNA repair disadvantage, and so they have undue toxicity during regular transplant. This regimen uses no radiation and no alkylator-based therapy, such as busulfan or cyclophosphamide, and this will hopefully have a huge impact on the risk of second cancers. Because these patients can't repair their DNA, like Fanconi anemia patients, they have an enormous incidence of squamous cell carcinoma of the oral and GI tract, and if you have graft-versus-host disease or you've gotten prior radiation, that incidence skyrockets. So this is a very, very gentle conditioning regimen and builds on previous reduced intensity conditioning experiences. The problem may be that it's not strong enough and patients will reject those grafts, in which case hopefully they can go on to a second transplant, but something like this that is so mild and can mostly be done outpatient would be a perfect approach to now import to Cairo after we have done 2 or 3 patients on the trial. Luckily, we have twins in the waiting who already are going to be enrolled, and even before the protocol opened, we have 4 patients. So it's written for 10 patients, and we may be done with accrual in a year, at which point the hope would be to open it here. The other thing Alana and I have been talking about for 2 years now, sadly, is how to approach the patient without a family-related donor in Cairo, as well as with our colleagues in Lebanon and Saudi. So, there's many ways. One can get an unrelated donor. It's expensive, it's cumbersome. It's not clear that people with more African Mediterranean background will have the same choices of donors that people from Northern Europe have. You can have cord blood units. They're expensive as well and hard to come by. And then there's a new approach where you give, and then what's been around as the final alternative for years has been haploidentical transplant, where you use a mother or father as a donor. The problem is when haploidentical transplant was first begun, it required T-cell depletion of the product, which is costly and dangerous and leads to very, very delayed immune reconstitution. And so about a decade ago now, the group in Baltimore started giving Cytoxan 48 to 72 hours after the stem cell infusion to decrease graft rejection and decrease GVHD. And it turns out that Cytoxan actually is more immunosuppressive than cytotoxic and will actively attack the proliferating T cells once they've had an initial antigenic challenge. It's been used as monotherapy in both related and unrelated transplants that were matched, not haploidentical, with very, very good results. And so our goal is to give stem cell infusion using a haploidentical donor and then give Cytoxan on day 3 and 4. This will solve a lot of problems. 95% of people have a haploidentical donor. Your parent is haploidentical for you, so unless you're an orphan, you definitely have one. It's much faster and less expensive than procuring unrelated or cord blood donors. And compared to traditional haploidentical programs, the lack of T-cell depletion is very advantageous because there's fewer infections. The hope is there's better immune reconstitution, and it's much easier from a regulatory stance. Moving on to patient care, which in a sense is probably, I think, to all of us the most important mission of an academic teaching center. In the past and currently, we have done some patient care sharing. We've had anecdotal conversations about complicated patients, mostly when I call it 2 a.m. my time, fretting about whether I should transplant someone or what bizarre complication they have. And we've also had discussions about how to develop oncology programs in resource-poor African countries such as Rwanda. But the future plans that Alana and I have been discussing is that we should really have standardized, formal, twice-monthly video conference calls with a didactic component where we review patients from both programs. And I've begun to do this. I've done it now for 2 years with Dr. Gerard in Riyadh, and I am beginning to do it in Rwanda, even though there's not pediatric oncologists there. And you have a set time, and you both bring your patients, and you do 5 minutes of teaching, usually around a patient. So if a patient has a fungal infection, one of the people present gives 5 minutes on voriconazole, the uses of it, side effects, whether you get levels or not, and then you discuss the patients. The other thing I would love to see happen, and I think it would be both an immense learning experience for us all and an opportunity to write an incredibly important position statement for something like JAMA, is to have monthly calls to discuss who to transplant and when. And so we agonize about the patient, whether you transplant a patient who is difficult. And patients can be difficult because their family situation is poor, their mother can't take care of them when they go home. They can be difficult because they have very advanced disease and we think the chance of cure is very low, or they can be difficult because they have antecedent comorbidities such as fungal infection that makes the risk of transplant very high. And so in the past, when my successor before me led the program, she decided. It was the Mubarak regimen. So you got transplanted if she said so, and if she said you didn't, you didn't. There's a lot to say for that, being the Mubarak person, because you get to make all the decisions and you don't have these lengthy, cumbersome conversations with people who disagree with you, which is always unpleasant. But at the end of the day, everyone needs to buy into transplanting these patients because the likelihood that things will go wrong is enormous. And if the nursing staff, the physician staff, the psychosocial people don't believe you should transplant these patients, they end up not understanding why you have these failures or these difficult problems. So we've started requiring a consult from our advanced care team, which is also like our palliative care team and is multidisciplinary. And we have a team meeting about any patient that we think has a high probability of not doing well in transplant. We make up to say if you have a greater than 80% chance of failing, then we have these meetings. Now that I've been working in Rwanda, they bring the same patient issues. Do you transplant this patient? Do you transplant that patient? They can't transplant, send them to America. Do you give chemotherapy to this patient or that patient? And I'm sure you have similar patients as well. And I think if we could set this up, keep minutes from it, and just record our decisions and the discussion that went on, that would be incredibly useful. And instead of, Dr. Hanafi transplanting a patient that he decided and everybody else standing in the corner saying, what was he thinking about? This patient's going to do abominably. Everybody would own that decision, and it ends up working much better. The final pillar of the academic hospital is global outreach. We've done nothing to date as a joint venture, but I think this is probably the most exciting place when I think about the future. So this fellowship here is going to be based at 57357. It's going to draw fellowship applicants from the whole Middle East, North Africa region, and it's going to give consistent, high-quality, jointly managed training for physicians who want to do stem cell transplant and actually all of pediatric oncology. And then, as new transplant programs or new oncology programs are developed through this region, you here are going to be the leaders in doing that. And you will know how to set up a program, how to set up quality improvement initiatives, how to meet regulatory guidelines, how to deliver good multidisciplinary care. And you will be the prow of the ship as the next stage takes place. And that too is something that needs to be studied and evaluated and written about, because that will be the legacy from here for the future going forward, not only for the Egyptian patients, but for the entire region. So in conclusion, I'd like to say that the successes are truly mind-boggling, that so much has been done in such a short period of time. We, between Boston and this hospital, have built a relationship that is based on true collaboration, and I've traveled around the world, as have my colleagues, and you can go to Pakistan and give a lecture once, and that's not collaboration. This is mutual understanding, mutual respect, and that relationship will only continue to grow. It becomes deeper and deeper with time. That collaboration involves all levels of both BMT programs: consultants, fellows, medical students, residents, nurses, pharmacy, and that gives it an incredible strength. It brings incalculable mutual benefit to all of these levels in both programs. What we learn from our collaborations with you, and what I hope you learn in our collaborations from us, can't even begin to be measured. And this is a truly, truly innovative approach. Nowhere has done something with this amount of interdisciplinary, cross-cultural interface on a weekly basis anywhere else. And we can generalize that to other programs and to other countries going forward. So, the final slide, the world is a very, very small place. And the distance between Boston and Cairo, I'm sure, the last hour of the 12-hour flight seems very far, but it really isn't very far at all. And I think both of my colleagues have talked about this. There's something very magical about the collaboration that we feel when we come to Egypt. And I have been thinking a lot about it on the 12th hour of the flight. And I think that we're very similar people. I think that Boston and Egypt, or Boston and Cairo, the people there share their underlying ideals in a way that we don't often put into words. On the good side, we both are very, very proud of science and intelligence, and believe that knowledge is much more important than money or acquisitions, things that you own, and that what we are passionate about is learning and teaching and making the world a smarter and a better place. And that's a very Boston-based thing compared to some of the other areas of America. The other thing is we're very independent, and we're also very proud people, and that can lead to some, very nice firestorms occasionally, but also I think makes for mutual understanding, that we believe that we know what's right and that we need to bring that to fruition. And then there's something else that really doesn't have words for it, so that we feel connected to the people here in this hospital, now having been again all over the world in a way that is just is, and we can use that to build going forward, and we will always be together in some way or other, and I hope that will bring ongoing benefit to all of us. Thank you.